So the Selena trial looked at the safety of oral contraceptives in lupus patients, and what they were looking at was to make sure that using these patients did not increase the baseline risk of flare rate. And the women who participated in this study had the characteristics that I mentioned on the earlier slide regarding their current disease activity, their risk of thrombosis, the presence of those autoantibodies that I mentioned that might increase the risk of clotting, and they used this low-dose oral contraceptive. And of the 183 women who received this, about half got the oral contraceptive, and about the other half got the placebo. And in this case, you can see that 7.6% of the patients who received the oral contraceptive had a severe flare, measured by a validated disease activity index. And the women who did not get the oral contraceptive had almost the exact same flare rate. So this would indicate that when you compare the women on oral contraceptives, or OC, as abbreviated on this slide, versus P for placebo, there was no difference whether you took the medication or not in terms of putting you at risk for having a severe flare. Now, severe flares are in general not very frequent, so they also measured mild and moderate flares and compared the two groups, those who received oral contraceptive and placebo. And again, you can see that the rate was virtually identical, 15% versus 16%. So in this case, the drugs, taking the oral contraceptive, did not increase your risk of having your lupus get worse. You always have to worry about side effects of medications, irrespective of whether we're talking about lupus. And so here, adverse events, or abbreviated as AEs here, were reported during this trial of a year, where patients had problems with renal disease. DVT is a deep venous thrombosis, or one of those clotting events, or a superficial clotting event for thrombosis, death. And when you looked at all of these potentially bad side effects, there was no difference. They occurred equally in both groups. And in fact, some of the events occurred after study drug. And so again, you weren't causing new problems when you were giving the oral contraceptive. So this study would give you some guidelines as to how to think about how to counsel someone if they wanted to go on oral contraceptives. Importantly, this graph, I think, just summarizes everything that I just told you. If you look at the graph, the x-axis shows you the number of days that patients were on the study, and the y-axis shows you the cumulative probability, or how likely was it that your lupus would get worse. And if you look at the graph, the red line shows the patients who were on the oral contraceptive, and the dotted line shows you the patients who were taking the placebo. And you can see that the lines are virtually identical across the study. So this summarizes what I just mentioned earlier when we're talking about the probability of severe flare, and the mild-moderate flare graph would look similar, that there was no difference and we did not cause more lupus problems. And as we also talked about before, there were no new other non-related lupus problems that occurred if you took the contraceptive. Because this young woman is Hispanic, of Hispanic descent, and it is known that those women may have an earlier and more severe risk for renal disease, it's very important that she get treated. And again, she may want to know, well, what would happen? Are there any specific is there any specific information available on using oral contraceptives in someone like me? And in this study, this was done in Mexico, where they compared several different kinds of contraceptive methods, including the combination pill, which would be very similar to what we talked about in the previous study. They also used a pill that just had progesterone, not estrogen, and they also used one of those IUDs, or barrier method. And if you look at this graph, you can see over time, it didn't matter which one of those treatment options you chose for contraception, there was no increased risk of flare using the same disease activity measure that was used in the previous study. So you can say, and yes, things have been studied in women like you, and again, each of these methods would be available to you, assuming that you met the guidelines for when you would at least think about using those medications. The next thing she's going to say, well, you have to make sure that my baby's okay, but will my lupus get worse when we plan for this in the future? And the following information will help you with your counseling on answering that particular question. So in this study, they looked at pregnancy complications in lupus, and they asked the question, are they more frequent in lupus patients compared to women who did not have lupus. So this is what we call examining a proprietary database. So this is a national database that has information on pregnancy outcomes, whether they're good or bad, and what happens to the mother, and also what the mother's underlying disease is. And the pregnancy complications that they looked at was, did they have to have a cesarean or surgical delivery? Did they have early labor? Was the baby small with growth restriction when it was born? Did the mother have a condition called preeclampsia, or even the more severe version of that called eclampsia? And then in the next column over, we give you the frequency of the women who had those complications if they had lupus. And the next column, in the middle column there, shows the women who did not have lupus and whether or not they might have had that complication. And you can see in every instance, whether we're talking about surgical delivery, preterm labor, or things related to the baby's size, or this preeclampsia or eclampsia syndrome, women with lupus had this complication more often than women who did not have lupus. And their risk of this was anywhere from 1.5 times to almost 4.5 times the general population. So this would show, just doing a survey, that women with lupus have more trouble with pregnancy, and hence the attention that we're giving today to try to minimize those complications for mother and for baby. So to drill down on what we need to do in terms of the impact of pregnancy on lupus, about 50% of the women will have some measurable disease activity during pregnancy, but this may not always constitute a flare, because most of the time this is going to be something mild like extra skin rash or joint pain or slightly low blood count, in this case platelet count, but most of those things can be managed. But anywhere from 15 to 30% of the women will have some type of active disease during pregnancy, and the risk of that is increased if you have active disease within 6 months prior to conceiving, if you've had multiple flares in the previous year, and if you've abruptly stopped medication and you have no medicine on board to take care of your lupus, assuming that the doctor feels that that was necessary. So this is an example of what might happen if you stop medication or not be on medication for lupus. And this is a summary of pregnancy outcomes, and mostly what happened from the mother's perspective in the Johns Hopkins lupus cohort. So what we're looking at in group 1 are women who were not on any medication, and specifically hydroxychloroquine or Plaquenil. Group 2 were the women who stayed on their medication, and group 3 were women who discontinued the medicine as soon as they found out that they were pregnant. And what these investigators looked at was a global score of disease activity, which is abbreviated here as SLEDAI, and then they drilled down at some specific symptoms, and the ones that I mentioned occur most often are fatigue and arthritis. And they looked at other medication, and the one most commonly used during pregnancy was prednisone. Was it used, yes or no, and actually how much did they need of this medication in terms of dose to control the symptoms. If you focus on column 2, under group 2, you will see across the board that those women were less likely to have active disease, less likely to have fatigue and arthritis, were less likely to need prednisone, and needed less prednisone when they did need it. So this would indicate that treatment should be seriously considered during pregnancy, because it gives a much better outcome for the mother, and as you'll see in later slides, a healthy mother gives us a best chance for a healthy baby. And this is the example of how treating mother and making sure that her disease is controlled has the best outcome for baby. So in this situation, if you see a white bar, that means the mother was sick. And if you see the blue bar, that means the mother was not sick. And the good outcomes here are live birth and what we call AGA, or appropriate size for gestational age. So the baby was born at full term and was also of a proper size. And in this case, you can see that the vast majority of those women had low disease activity. The outcomes that were not ideal, where the baby died and there was mortality, the baby was born early, or the baby was born too small, which is the SGA abbreviation for small for gestational age. You can see in every one of those cases, the women were more likely to have high disease activity compared to low disease activity. So if a woman is afraid to take medicine, it's really imperative to say it's very important to control your disease activity, because it's better for you and better for your baby.